with the Heart of Medicine, and this is Internal Medicine Pearls video number 23. So these are 22 or 23, I think 23 consecutive days of putting out these videos nonstop. So yeah, we've been pretty efficient and effective. And this is another one just sharing with you the Internal Medicine Pearls. And of course, this is going to help you a lot if you are preparing as I am for the Internal Medicine Certification Examination, the ABIM, right? That's what it stands for. Or Step 2 CK or Step 3, and maybe a little bit for Step 1, probably not that much because it's not so clinically oriented. And the idea for these videos is because I noted that there's only so many videos online that you can just put on the AirPods and go walk the dog and actually learn some medicine and get prepared in medicine. And sometimes life is so busy that we don't have any time to get home and actually study one day. So sometimes it's useful to have these videos out there. So okay, this is my attempt to fill in that gap. So without further ado, let's get into the action. So question number one, what's the clinical pearl here? Well, there's some questions that have way too many findings, and the more findings a patient has, the more you have to be able to associate everything with a specific syndrome or a specific condition. So in this first case, you can see that this is a 43-year-old female. She has weakness, she has arthralgia, she has a rash that is below both of her knees, consisting of many raised erythematous papules. She has lab derangement, so she has bicytopenia, meaning two cell lines from bone marrow are low. One is the anemia here, and another one is the leukopenia, which you can see right here. She has kidney compromise, she has transaminase elevation, she has hematuria, she has proteinuria, she has low complement levels, both C3 and C4 are low, and she has an elevated rheumatoid factor. So if none of this rings a bell, probably you just don't know what's going on, because these are already 10 things in this patient. So the question here is, what's the most helpful in establishing the diagnosis in this patient? So they're not asking you about what this patient has, which is the first thing you have to coin, because with that, then you can go to the options and think, okay, which one of these can help me? So what I want you to think about here is, remember the diagnosis is called cryoglobulinemia. This is what this patient is having. So this is a cryoglobulinemia case. Cryoglobulins means globulins or immunoglobulins, meaning antibodies that precipitate with cold temperature. Cold temperature would be less than our body temperature, so less than 37 degrees Celsius, which is our regular body temperature. So what happens? It's a sort of small vessel vasculitis that occurs, and it can affect all these different organs. And cryoglobulinemia starts with a C. And yes, it is associated with something that starts with a C, hepatitis C virus. So that's why viral hepatitis serology was what was helping you here answer this question, because there are different, well, cryoglobulinemia, yes, there are other types. Okay, so first of all, there's type 1, there's 2 and 3. All that I want you to think about is type 1 cryoglobulinemia is usually a monoclonal spike. So just one specific sort of antibody is being performed. Usually that antibody is going to be, or that condition is going to be multiple myeloma, or here we have it, multiple myeloma, or in the setting of CLL, chronic lymphocytic leukemia. And type 2 and 3 are several different antibodies, so it's going to give you a more even, more clinically or florid picture. So that's going to be types 2 and 3. So what happens here? Well, in type 1 cryoglobulinemia, you can have asymptomatic patients, which will be the most common. You can also have hyperviscosity sort of syndromes, giving you blurry vision or thrombosis, livedo reticularis, and skin necrosis. Complement levels will be normal in type 1 cryoglobulinemia. So in type 2 and 3 cryoglobulinemia, you will have a low complement level, especially C4. You can have a normal C3, but almost definitely the C4 will be low. In our case, both were low. Okay, so usually when complement is low, it's telling us disease activity, autoimmune disease activity, right? Meaning that the complement is just battling around and precipitating and becoming immune complexes in different parts of your body, and that's why it's going down on the blood levels. So type 2 and 3 cryoglobulinemia or mixed subtype is going to be due to hepatitis C or HIV or some autoimmune conditions such as lupus. And clinical features will be more florid, such as this patient, so fatigue, arthralgia, palpable purpura, glomerulonephritis, and peripheral neuropathy. And what else can we see? Let's look at a picture for palpable purpura. So yeah, this would be palpable purpura, and usually it's non-blanching. So if you press on it and you just let your finger go from there, it's gonna remain the same color. That's how you can differentiate a telangiectasia from something like this, or how you can also differentiate, what is it? I believe petechial, what is it? Petechial, yeah, a rash from this. Let me know if I'm incorrect with the petechial one, but okay, let's go on with the rest. So we already spoke about all this. Some other things is livedo reticularis can be seen in type 1 cryoglobulinemia, but other things where you can see livedo reticularis are antiphospholipid syndrome. So livedo is like, it reminds me just like, you can see the vasculature, you can see like roots, right? Sort of things. You can see like a little trail to them. Doesn't look good at all. Like livedo reticularis, you also see it post-mortem. So that's something for you to think about. So antiphospholipid syndrome, type 1 cryoglobulinemia, and also post-mortem, it sort of looks like that. So then what else were we thinking about? That's it for that question. Now we're going to the next question. So whenever you see this image, just focus on this image a moment. And yeah, it's tough, right? Because if you just look at it and you're like, what's this? If you're a dermatologist, maybe you're like, oh yeah, this is such and such. But if you're not a dermatologist, probably it's a little more difficult. You just see it and just see that. To me personally, the way my brain sees this is as if this patient like got sort of burnt, like a burn something hot was on the skin. It looks like different little burn sort of scars that became hyperpigmented after being exposed to the sun. That's how it sort of looks like to me, at least this image right here. But yeah, always take into account that there are some dermatological conditions that, of course, have their own name. And now when I'm going to say this mnemonic or these different descriptors, now you'll be like, oh, it's that thing. So look at this. So it's going to be purple, right? It looks purplish. Some of them are polygonal. Some of them are, well, they are painful. So purple, polygonal, painful, plaque, all that is trying to make you coin the term lichen planus. So lichen planus is what's going to give you these findings. So this is basically what this patient has. It says that the patient was diagnosed with hepatitis C infection 6 months ago, was not getting any treatment, and now has these findings. So yes, lichen planus can be associated with hepatitis C as well. And what was the treatment? So now the question is, what's the treatment? Treatment is topical corticosteroids. Okay, that's the treatment for lichen planus. What's the treatment for, when would you do topical vitamin D? So calcipotriene is a topical vitamin D, and that's usually for, isn't that psoriasis, I believe? We'll check it out in a second. I believe so. Oral lamivudine is for hepatitis B, not hepatitis C, and it is to control sort of hepatitis B. And topical antifungal doesn't make sense here because this is not a fungus, and emollients won't work. So lichen planus, remember the 4 P's: pruritic, purple, polygonal, and plaques or papules, and most commonly occur on the flexural surfaces of the ankles and wrists. Lesions may show lacy white markings known as Wickham stria. So I'll show you Wickham stria right here. These stria right here, this whitish thing. And of course, shout out to UWorld. It's the best question bank out there, hands down. And as you are seeing, the explanations are so to the point, so great that it's a definitely, tier A, tier 1 question bank. If you are not sure if this is lichen planus and you have not diagnosed this clinically because I'm not sure, do a punch biopsy. And of course, we talked about the treatment, which is topical high potency corticosteroids first line. And if they don't respond, you can do systemic steroids or phototherapy. We already spoke about vitamin D, that was psoriasis. And let's go on to the next question. Let's see what else we can have here. That's about it. Okay. Now, next question. This is an important question because in my case, when I think about amyotrophic lateral sclerosis, or also known as the Lou Gehrig disease, I always think, yes, it is motor, only motor. So anything that gives you motor symptoms, you might have the ALS in the picture. But what I usually thought of ALS was usually just flaccid, just decreased strength, just decreased reflexes, and I thought of it as being symmetric. It's not symmetric. So ALS is asymmetric. Okay, number 1, motor. Number 2, asymmetric. Number 3, upper motor neuron and lower motor neuron manifestations. And that's so important because that's made me fail many questions in the past, because I see that I find out on the question stem or clinical vignette that it says that the patient has, for example, both tongue and muscle fasciculations are present. That's a manifestation, I believe, of upper motor neuron. They also have some, here you see some upper motor neuron syndromes, symptoms such as ankles with bilateral extensor plantar responses. Okay, and yeah, increased reflexes in some areas. So don't get mixed up. So remember that upper motor neuron and lower motor neuron alterations are part of ALS, and you can also have motor manifestations in other muscles such as speaking. So you can have dysarthria. That's why this patient has such a nasal voice, a nasal quality voice. And let's see what else we were missing. So upper and lower motor neuron manifestations. Let's just review that real quick. Remember, lower motor neuron is just everything is sort of flaccid and sort of decrease in strength. And I was wrong. Fasciculations are more seen in lower motor neuron and weakness and atrophy. But upper motor neuron signs are spasticity, hyperreflexia, and even pseudobulbar affect, such as inappropriate crying or laughing. So if anyone here knows how this pseudobulbar affect is associated with a motor disorder, let me know. That's interesting. Okay, and that's it. We got this question correct. So we already spoke about all this. And of course, median survival time is approximately 5 years since diagnosis because of the respiratory failure. So they then have difficulty breathing, and that's a most common cause of death. So now we're going on to this next question. This one's very, as you saw, I underlined a whole lot of things there because I find this very interesting. This question is just trying to make you understand the problems, some problems that can happen with the technology, and it's alert fatigue. So they're just telling you that a hospital has a rare but fatal adverse event, and a root cause analysis finds that basically a doctor prescribed a medication that had a medication to medication interaction, and that was problematic and generated a human demise. And what the hospital did or implemented afterwards was a system-based approach or not system-based, they basically added way more pop-ups or way more, they added, when you use the electronic medical record, now you're getting all these different warnings and precautions that this medication can interact with this other one. So they updated the database, increasing the number of recognized drug interactions from 60,000 to 200,000. So what happened? Then a year later, they checked what was going on. So a quality improvement team found out that the number of prescribed drugs with high risk interactions actually had increased, opposed to the expected effect of a decrease. And what happened here? It was alert fatigue. So it basically meant that there was a fatigue of getting so many alerts. Imagine being working on your medical record and seeing a patient, and you're gonna order X medication, and every time you are going to order something, it tells you this medication interacts with this other one. After you've seen that same sign or same precaution warning 100 times, then you'll just start ignoring it because it's just oversaturation. It's saturating you with too much information with things that might not be so risky. So that's called alert fatigue. And the way you reduce alert fatigue is, of course, reducing the number of alerts to what is going to be strictly necessary and just to the highest risk things. So here you have alert fatigue. Healthcare workers become desensitized to all clinical alarms and alerts, including those of clinical significance. So this happens all the time in the ICU, that there's alarms going off every moment you get into the ICU. There is an alarm always. So sometimes being able to figure out which alarm is important and which is not is difficult. That's why there's so many different sounds for these alarms, and all the beeping of the infusion pumps. Yeah, it definitely can generate alert fatigue. So anything that can reduce the alerts to what is actually real or important is gonna improve outcomes. So some examples, we already spoke about them. Prevention strategies: minimize environmental distractions, reduce alarm frequency and false alarms. And that's about it for this one. So this question also teaches us the importance of having quality improvement projects. Just because you think or you assume that an intervention will improve things doesn't mean that it will. That's why quality improvement projects require you to measure things before the intervention and after the intervention to make sure that actually it's working and helping, right? And that's it for this question. Let's go on to the other question. This other question right here, 45-year-old female, has an intensely pruritic rash. So you can see here, there's sort of a rash. I'm not sure if it's like papular, right? Looks like maculopapular rash all over. So it's bilateral, and it's near the buttocks. It's also on the arms, on the extensor surfaces. So it's all over. The patient has no significant medical history, and here it says rash, pruritic papules, and blisters on all extensor surfaces, basically for 2 months. Very pruritic. So what's going on here? Okay, so the question is, this patient's condition is most likely associated with which of the following? So they want you to think about what the diagnosis is and then to associate it with something. So let's look at the options. Ulcerative colitis, no. Ulcerative colitis would be associated to erythema nodosum, which this is not it. Or pyoderma gangrenosum, this is also not it. Lung cancer, not sure what skin manifestation. HIV infection, could be associated with disseminated, like psoriasis, disseminated seborrheic dermatitis, this is not it. Or Kaposi sarcoma, nope. Hepatitis C infection, no. Cryoglobulinemia or palpable purpura, this is not it. So iron malabsorption, why is that the answer? It's because iron malabsorption is associated to celiac disease, okay? So this patient had celiac disease, and celiac disease can be associated to dermatitis herpetiformis. So that's what's going on here. Hepatitis herpetiformis, there's no herpes here. It's not herpes, but that's how it was named. And just so you know, yes, that's how it sort of looks like. So skin conditions and associated diseases, we already spoke about several of these. And let's see, what else can we speak about here? Celiac disease with dermatitis herpetiformis. And let's see. Yeah, that's about it. Many patients that have celiac disease, that have mild celiac disease, may be asymptomatic and have like this subtle anemia due to iron deficiency, because remember, celiac disease is associated with some iron deficiency, also potentially calcium deficiency, and a couple more electrolyte abnormalities. So anyone that has iron deficiency anemia, maybe if you have a couple more clues, you might have to think about celiac disease. And whenever you see dermatitis herpetiformis, you have to think about celiac disease also in the mix. You diagnose it clinically, but it can be confirmed with a biopsy. So on a biopsy, you'll see neutrophilic infiltrate, papillary microabscesses, and subepidermal vesicles. Direct immunofluorescence of perilesional skin shows granular IgA deposits in the dermal papilla, and is more specific than light microscopy alone. And of course, there are some serologic markers for celiac disease, such as IgA tissue transglutaminase antibodies, IgA anti-endomysial antibodies, and that can be helpful. Initial management, of course, is going to be gluten-free diet, and for the dermatitis herpetiformis, yes, dapsone. And that's it with that one. Now we're going on to the next question. This next question, look at the image. Just by seeing the image, you should be able to know what the diagnosis is. So make this consolidate in your brain. So if you see this sort of a rash here in the face that involves the nasolabial folds and also is sort of scaly and looks sort of oily, that's called seborrheic dermatitis, okay? So if you have seborrheic dermatitis, what's your treatment? Oh, and seborrheic dermatitis is associated to Parkinson's disease and also, I think, dementia, other causes of dementia, maybe HIV as well. And for anyone seeing this video, why would you say seborrheic dermatitis incidence is increased in patients with Parkinson? Would you find an explanation for that? Let me know. What do you think? Okay, so the treatment for that is low potency steroid cream and antifungal cream, because it is thought that seborrheic dermatitis can be associated with Malassezia furfur. Sorry about that. So that's post-nasal drip, okay? And yeah, it sucks. And the treatment for post-nasal drip is usually the inhaled corticosteroids, and maybe sometimes a little bit of saline. So I'll use that in a little bit, okay? So going back to this, you should never use high potency steroids on the face because, of course, that's not a good idea on the face. So that's why it's always low potency steroid cream on the face. And the antifungal will help for seborrheic dermatitis. And that's about it. Let's go on to the next question. This next question is a 55-year-old man. The main things they're showing us here is that he has decreased early morning erections and sexual desire. He also has inability to maintain satisfactory erections during intercourse. So basically, first consideration you have to make in a patient that has erectile dysfunction is this psychological or is this like organic, right? So how can you differentiate? The main thing is if this patient is having erectile dysfunction, but they're telling you that they have normal morning erections, it's probably psychological. But if they're telling you that early morning erections have decreased, that's not psychological at all. So that would be more organic. So this question is telling us there is something going on that is not psychological. So the testes, here you can see the testes on physical examination are normal in size, but have a soft consistency. So they're also telling you, okay, erectile dysfunction that seems organic in nature, okay? And also testes are soft. So they're all now telling you this might be hypogonadism, right? They're now telling you there's let's see. They're telling you that there's primary hypogonadism. That's what they're sort of trying to tell you here. So what do you have to do? First step is always measure the total testosterone. And since the testosterone can fluctuate, you have to repeat it. So if the total testosterone is low, you don't treat yet. You have to repeat testosterone again. And if it's low again, okay, then you can go work that patient up. So first thing is that once you confirm that total testosterone is low, then you have to check LH and FSH. This is going to tell you if the problem is up right here or if it's down there. So if the LH and FSH is elevated, it means that the brain is trying to stimulate the gonads and the gonads are the problem. So if that's the case, yes, it's primary hypogonadism. But if our patient has low to normal LH or FSH, it means that the problem is up here, that the gonads are fine, but they're not receiving the signal from here for the factory to work. So that would be secondary hypogonadism. And of course, if that's the case, you have to image up here with MRI to check, and you have to check also prolactin, iron studies, and other pituitary hormones. Okay, so we already nailed most of the points there, and that's it for that question. We're going on to the next one. So in this next question, let's see what this question is just telling you a 45-year-old woman all of a sudden is developing diabetes because she's 45 and she's having polyuria, so she's having frequent urination and increasing fatigue over the last 2 weeks. How do I coin that she's developing diabetes? Because she has frequent urination and you go to her labs, everything looks normal except her glucose in a fasted state, which is 250. Any glucose above 200, even after eating with symptoms, is suspicious of diabetes. You can have a glucose above 200 for a moment after eating, and if you're asymptomatic and if it comes down quick, it might not be diabetes. But in this case, of course, that's very suspicious for diabetes. And what does she have as well? She has moist mucous membranes and scattered areas of skin depigmentation. So it seems like she also has vitiligo. So you have this patient that is 45 with vitiligo, with sudden onset sort of diabetes that is symptomatic, and family history of let's see, patient's journal. Well, she also has discoid lupus erythematosus. So they're telling you this patient is heavy on autoimmunity. Discoid lupus, vitiligo, now developing diabetes. And basically, they're also telling you that there's a family history, I think, here. Family history. Let's see. No family history. But that's enough. With the information that they have provided, they're basically telling you, okay, this patient might have an autoimmune cause for diabetes. And how do you test for that? You usually test anti-glutamic acid decarboxylase antibodies. So that's the main one. And there's also another one is was it decarboxylase? Let's see. ICA or IG. Glutamic acid decarboxylase antibodies. Okay, that's one. There's another one. Let's look. Anti-islet cell antibodies. Okay, that makes sense. That's like they're just giving it to you, right? The islet cell is where the islets, in the pancreatic islets, is where the endocrine function is, basically where all these endocrine hormones are generated. So that would be very intuitive. So probably they won't give you the answer that easy. So glutamic acid decarboxylase makes you think more. You're like, what antibody was that for? So yeah, it's for autoimmune diabetes. So that would be latent autoimmune diabetes of adulthood, or LADA. Usually the onset will be between age 30 and 50. It's subacute or acute onset. Patients usually have a normal BMI less than 25. Personal or family history of autoimmune disease is also in the mix. And here you have a little table how to differentiate these. Of course, just going to mention some more specifics about LADA, which is the topic, our question here. Diagnostic tests. So you will have a low C-peptide for the autoimmune diabetes. Remember that C-peptide is made in a 1-to-1 proportion of with insulin. So since we can't measure insulin that well, we can measure our endogenous production of insulin with the peptide C usually. So peptide C, if it's low, it means that our endogenous production of insulin is also low, which that would go against type 2 diabetes, because in type 2 diabetes, you would have an elevated production of insulin and then the insulin resistance, and if that keeps on untreated, eventually the pancreas will burn out after 20 years, right? But in this autoimmune diabetes, you will have sort of quick reduction in the C-peptide. And these patients with the autoimmune diabetes end up becoming similar to type 1 regarding management. They will end up requiring insulin, but not immediately, but usually way quicker than type 2 diabetes. So it's going to take them between about 6 months or a little over 6 months for them to fall into this insulin requiring diabetes management. And that's it for that question. And let's go to the next one. So this next question is a 35-year-old male with HIV, which has acute onset severe perianal pain for the last 24 hours. His pain is 9 out of 10 and burning in quality. His CD4 count was 340, so it wasn't completely normal, but it wasn't in the range of AIDS at all. So okay, he ended his 8-year relationship with his male partner 1 week ago. So 1 week ago, what they're basically sort of trying to make you think here is, so 1 week ago they ended the relationship and he denies any other recent sexual encounters. So there has not been any trauma to the area in question, which is the perianal area, because there are 3 superficial, highly tender, ulcerated lesions located in the perianal skin area. There is mild, non-tender, generalized lymphadenopathy. And the question is, what's the most likely cause of this patient's condition? So I'm thinking to myself, like, okay, there are ulcers, and I do remember that the ulcers here, the ones that hurt were herpes and chlamydia. Remember with chlamydia, you do cry, so it hurts. The ulcers hurt, and herpes, yeah, it also hurts. The question was, which of the 2 of those was it? So with herpes, usually you have more ulcers. You have more lesions. With chlamydia, trachomatis, you usually have less amount of lesions. And yeah, in this case, you had 3 ulcers, highly tender, and lymphadenopathy sounded more like herpes simplex. So that was the right answer. Let's see what else we can differentiate here. So here you can have that infectious genital ulcers that are painful are herpes and Haemophilus. Oh, and the other very important point was that it was, yeah, the Haemophilus ducreyi. Haemophilus ducreyi. Oh, we just saw in real time how my brain had mixed up or confused this microorganism. So Haemophilus ducreyi, you cry, okay? But it's Haemophilus. It's not a chlamydia. It's Haemophilus. So painful lesions, herpes, and Haemophilus ducreyi. But the painless ones are syphilis, produced by treponema, and chlamydia trachomatis. So that option was incorrect. So that's why that's why the answer was even easier for anyone that could make that distinction. And what else do we have here? That's about it. The test probably won't make you have to choose between herpes simplex and Haemophilus ducreyi. They will probably make you choose between painful and not painful, because that way they can test you remembering which one did hurt, which one did not hurt. And that's sort of it for that one. Let's see what else. Genital ulcers are most commonly due to herpes simplex virus or syphilis. Syphilis causes a single ulcer. Painful genital ulcers are more likely due to HSV or chancroid. Okay. Medical history and physical are not completely accurate, and all patients should be tested for both HSV and syphilis. And further testing is based on these initial results and response to therapy. That was that question. Now let's go on to the next one. This is an 18-year-old male patient, a soccer player who is just brought into you for an abnormal electrocardiogram. So basically he is asymptomatic. So an asymptomatic soccer player which has T-wave inversion in leads B1 and B2. And we have some auscultation at the cardiac apex, which I will play right here. So let's listen to it. So how does that sound? It sounds like... I couldn't hear a murmur. Actually, I was taking this quiz without any earbuds on, and I listened to it, and I'm like, I can't listen to a murmur. Like, I hear that because sometimes I've listened to these without earbuds, and there's a slight murmur that then I put on the earbuds, and I'm like, oh, there's a little murmur here. Such as, for example, in mitral stenosis, the opening snap. So it has sounded similar to this that we just listened without the earbuds on. But when you put in the earbuds, you're like, So for anyone, taking the test or even quiz or whatever, always have your earbuds right there at hand. If you have to listen to anything on the test, make sure to put them on, have them ready once you start the test, just in case. And so I got this one incorrect because I did understand that this was a third heart sound. So this was S3. But what I didn't think about, because I didn't think about the possibility of not all S3 or third heart sounds being pathologic. So yeah, that's the clinical pearl. Whenever you have a third heart sound in a rather healthy young individual, it doesn't mean there's a problem. It can be completely normal, such as this patient. So it was a normal finding in this patient. The T-wave inversions in this EKG were non-specific. This patient is asymptomatic, and that was non-specific, didn't mean anything. But if this patient was a 50-year-old patient with new onset shortness of breath, for example, then the answer would be left ventricular enlargement, because we're talking about heart failure with reduced ejection fraction. So remember that usually when this is pathologic, S3 will mean a increase in dimension of the ventricle, right? S4 usually means a decrease in compliance. So a stiffer ventricle would be an S4. When you have an S3, you have to look at the age and how else the patient is doing. So in summary, if you have an third heart sound in patients over the age of 40, it is considered abnormal and suggests enlargement of the ventricular chambers. S3 can be heard in patients with chronic severe mitral regurgitation, chronic aortic regurgitation, heart failure associated with dilated cardiomyopathy, and occasionally in patients with high cardiac output states. So last thing I'll say is that if you have S4 is almost always bad. let's see what we have here. S4. S4 presence or fourth heart sound in young adults usually signifies an underlying abnormality. Mhm. But now it says that a fourth heart sound in healthy older adults is due to decreased ventricular compliance with age. Oh, so I'm not sure if I would agree with that exactly, because what I was taught in cardiology was that yes, S3 can be normal, such as what we just spoke about. But whenever you hear S4, it's always abnormal. You don't care what age the patient has. Here in this question, it says that if you can potentially have an older adult with an S4 and it being sort of normal aging, because with aging there's a little bit decrease of ventricular compliance. But I'm not so sure about that, because you know that when there's decreased ventricular compliance, there is an alteration in the diastolic function. So it could potentially be a marker of heart failure with preserved ejection fraction. But that's probably too specific for this right now, so we'll leave it at that and going on to the next one. So, oh, this question is very important because it's regarding an antibiotic we use so much, which is amoxicillin. So this patient basically had received amoxicillin some time ago and thinks she has penicillin allergy. So this patient now has some signs for cervicitis, acute cervicitis, I believe, or STD, secondary to gonorrhea, and it should be on ceftriaxone. But the important part here is that the patient had taken some antibiotics about 3 months ago. She took amoxicillin for a cold, and several days later, small red bumps developed on her body, but resolved in approximately a week. The rash was not pruritic or painful. There was no trouble breathing, dizziness, fever, eye pain, or sores in the mouth. So the question was, which of the following is the next step in management of this patient? So the most important thing in clinical pearl here is that amoxicillin is often associated with a rash that is not necessarily allergic. So whenever you have amoxicillin inducing a rash, first thing you have to think about is how many days after the antibiotic did the rash appear. If it is really quick, if it is within a day or a couple days, there's high likelihood that that is allergic, and of course not good. But if it happens many days after, there's high possibility that it is just associated to the medication without it being a actual allergy. So in this case, since the rash occurred, let's see, several days later, and there was no other compromise than the skin, it meant that the patient did not have an allergy and the patient could just receive the ceftriaxone, and there was no worry that this amoxicillin reaction was allergic, so no cross-reactivity with cephalosporin, so you could just reassure the patient and give the patient the cephalosporin. That was the right answer. Let's now review this with an algorithm here. So if you have amoxicillin-related rash, if the onset of the rash is delayed, typically days to weeks, it is usually non-IgE mediated. If it is maculopapular rash only, if the answer is yes, so it's a drug or viral interaction or viral exanthem. Most common diagnosis usually days 7 to 10. And you can just continue the antibiotics if necessary and can re-administer in the future, okay? But if you have that, there's not only maculopapular rash, you have something weird things going on, right? Any weird thing going on, yes, there's high risk of this being some sort of either allergy or another reaction. So that's why if you have fever and joint pain, it could be serum sickness-like reaction. If you have lesions in the mucosas, targetoid lesions, it could be Steven-Johnson or toxic epidermal necrosis, or erythema multiforme, or if you have eosinophilia, you can have Dress syndrome. So if it's any of those cases, of course, you stop the antibiotic, you avoid cross-reactivity, you avoid beta-lactam antibiotics, and consider allergy evaluation, okay? So that's that part of the algorithm. Of course, if the onset of the rash after the antibiotic is immediate, it means that, yeah, you have problems, and this seems to be allergic, and stop the antibiotic, etc., etc. So that's the most important thing there, and now we're going to the next question. This next question, let's see. Oh, this one was such a long question that I just looked at the options and I just marked this quick because I wanted to have some time at the end to review the marked questions. And as you can see, I got it incorrect. I didn't have enough time to come back to it. So what happened here? Okay, the most important things. As soon as you open this, you have hemodynamic parameters. So just seeing the hemodynamics, I would recommend you to go to the options and you can cross out some things just looking at the hemodynamics. And let's see this. Oxygen saturation, that's important because that's going to tell you if there's a communication somewhere. A communication that should not occur. So you can have a step up. You can have, for example, if in the right atrium, if in the right ventricle there is a higher, let's see, oxygen saturation than there should be, it could mean that there's a ventricular septal defect or ruptured ventricular septum. In this case, all of the saturations were the same. So it's just telling you there's probably no communication anywhere. They're just the same everywhere. The other thing for you to consider here is, of course, the clinical findings. So let's see if we can break this down. This patient is an 83-year-old woman who was brought to the emergency department with very severe chest pressure, with atypical findings. Yes, so remember that in females you can have atypical chest pain presentations, and that, of course, doesn't mean that you should just ignore it. It means that you should be even more cautious because you can have an obscure, an underlying myocardial infarction, but just an atypical presentation. So that's what they're basically trying to tell us here. Imagine that she even attributed the entire experience to drinking expired milk. So that's where you as a physician have to be very inquisitive and try to dig out any important findings. So you have that the patient was basically, yeah, having normal physical exam, but the EKG showed 2 millimeter Q waves in leads 2, 3, and AVF, meaning all the inferior wall had like pathologic Q waves. Lab results showed an elevated troponin and CPK or creatine kinase. Okay, so that should make you think, okay, wait a second. This presentation is atypical, but we're having some findings that we should maybe go pursue further workup. The patient was admitted to the ICU and scheduled for coronary angiography. And while she was waiting for the angiography, guess what happened? She became hypotensive all of a sudden, very tachycardic, and now having acute heart failure symptoms such as bilateral diffuse crackles and and the pulmonary arterial catheter showed these different invasive hemodynamics. So with that information, now you can go back to the question stem, right, to the options. This is not PE. This is not right ventricular infarction. This is probably papillary muscle rupture. This is a tough one, very, very tough one, because remember that the posterior medial papillary muscle in the left ventricle, so there's two. There's the anterior lateral papillary muscle and there's the posterior medial. The posterior medial papillary muscle is only, its blood supply is just due to the right coronary artery. So if you had the Q waves in the inferior leads, it means that the right coronary artery could have been compromised. And if that is compromised, you can have alteration, right, of the blood supply to the posterior medial papillary muscle. And since no one had intervened or checked that out, it can necrose and it can rupture. If that ruptures, it will generate an acute heart failure decompensation, such as the one we are seeing. The patient went hypotensive, went tachycardic all of a sudden. So yeah, that was the answer. It was not ruptured ventricular septum because we would have seen a step up in oxygen saturation right over here. So that's it. So this is a good table for you to probably pause and go through it yourself. Here you can see the different complications of mechanical complications, basically of myocardial infarction. So yeah, you shouldn't delay catheterization more than 24 hours for these patients that you might be concerned have myocardial infarction. And the patient had that inferior MI like 3 days before, and that's why when she came in, she was already having this mechanical complication, which was the papillary muscle rupture. Okay, so what else do we have? That's about it. Let's go on to the next question. Last question is they show you this image right here. Just looking at the image, both hands. So hands with erythema, right? There's a rash there going on. It's a macular rash. So a macular rash in both hands. So what are the questions? Urinalysis is normal. Which of the following is the most likely diagnosis? Okay, just looking at the rash in hands, you remember the mnemonic. Cars are driven with your palms and soles. So what gives you rash in hands and soles, although this is just hands, Coxsackie, what's the A? Is the A anaplasma? You tell me in the comment section below. Well, Coxsackie, rickettsia, syphilis, and that's it, right? Well, at least the ones I can recall right now from the top of my head. So you see if there's any of those options here. Well, just syphilis, okay. Now let's go to see the labs. There is thrombocytopenia and leukopenia. Of these, which ones give you thrombocytopenia and leukopenia? Probably the best one will be dengue fever, right? Let's see what else is going on. So this patient has, this is what gives you the answer. Throbbing pain behind the eyes, diffuse myalgias, and abdominal pain. So remember that retroorbital pain is basically dengue. Like if they're giving you any other clue for dengue fever, retroorbital pain should be the one that you're like, oh, this is dengue fever. So it's not pain in the eye, it's pain like behind the eye. And what other things did they give us for us to be able to get this? She noticed erythematous skin rash developing on the trunk and upper and lower extremities. Patient also had bleeding, episode of epistaxis, and syncopal episode when cleaning bathroom. So yes, this patient is hypotensive. This patient is having severe dengue. I would say probably hemorrhagic fever because there is epistaxis, which has happened twice already. So I'd say probably that is going on, and the lab abnormalities. So that's dengue hemorrhagic fever. Clinical features of dengue. So severe dengue. I would say this is severe. Let's see. Severe bleeding, severe organ involvement, severe plasma leakage causing shock or respiratory distress. So no, this wasn't yet severe dengue, maybe dengue with warning signs. So addition of any of the following: mucosal bleeding was present, yes, and abdominal pain was also present. So it would have been dengue with warning signs. What is dengue without warning signs? It is the flu-like febrile illness with marked myalgia and or arthralgia, diffuse maculopapular rash, leukopenia, positive tourniquet test. That's something that has to make you think about dengue. So you just put a tourniquet and you leave it there. You leave it there for about 5 minutes, and after that, after you loosen it up, or basically you'll see petechia in the arm. That's pretty painful. So nowadays it's probably not that recommended because yeah, the patient might sue you maybe, or maybe it's not even necessary. But that was probably some characteristic from the past. That's why, and that what that showed was capillary, capillary friability, right? Basically capillary leakage. And that's it. That's all we have for this one. Dengue fever is a common cause of fever in travelers returning from an endemic area, such as the Caribbean, parts of Asia, and South America. So this patient had traveled to Mexico, and that was it. See you in the next one. Let me know your comments, opinions. Peace.